Alright, morning everyone. Saya Dr. Fakrul Razi. Currently year 4 master student USM out campus in HSAH. So I got one MO texting me, enthusiastic MO, asking me what is the topic for today's journal so that he can do homework before I start presenting. But sadly, I'm not presenting journal today because for this week session for journal, we changed into a procedural sedation analgesia in ED. Just as a recap and a revision for all of us, because we've been seeing cases where ortho approach us for PSA, we let them to in charge of the PSA instead. So it's not right. So we have to revise back. How do we do our PSA in emergency? Okay. Right. So we know that there's a lot of procedure currently. It's been outgrown our services. All the CMR, all the procedures, chest tube. It's not just laceration and suturing anymore. So there's a lot of procedure going on nowadays in emergency medicine, in emergency department. So we need to use PSA approach. We need to optimize the pain control. So with this, later I will let you know from which resources that we use. So first, I have a questions to our audience at home. Saya punya request, boleh tak buka video? Kalau you boleh lah, kalau dalam toilet janganlah buka. Kalau you at home, at your study room ke, so boleh buka video and answer the question. Kalau boleh tak payah sebut nama lagi bagus. Senyap kan, semua lagilah tak buka video kan. Alright lah, saya pick lah. So, kita just a brain teaser lah, a brain teaser. Is fair? Is it fair for us to give a medication, not knowing how it works, not knowing the complication, not knowing the contraindications? So it's not fair, right? If you were to be the patient, I'm scared if someone giving a medication that the doctor doesn't know. So just a revision. EPs tak ada jawab, masa student FK pun tak ada jawab, so I think they most likely know already. So I want MOs to know lah the drugs that we use. So the one that I written here is Profketab. It's actually a mnemonic. So it's a propofol, ketamine, and mida. So first, I would like to pick not Dr. Husna, not Dr. Bear. I would like to pick probably M. Faiz Hesah. M. Faiz Hesah. Oh here. Okay lah, he's here as well. So M. Faiz Hesah, boleh bagi mic dekat dia. Faiz, propofol, how does it work? How does it work? How does it work, Faiz? Kita dah bagi propofol ni, yang tahu warna putih je kan? Anyone? Faiz?
Tak sure dah.
Tak sure, okay. Isak, propofol, Isak, how does it work?
Gabar.
Very good, Isak. Isak memang I know for so long already. So, propofol, they acts at GABA A. So, in our brain, we have two neurotransmitters. There's a lot more. But two major one is the glutamate and GABA. So, glutamate is excitatory. So, anything when the glutamate high, that's why you seizure. Your brain is hyperactive. There is hyperactivity of the neurotransmitter. But GABA, it make you relax. It make you sedated. So, it's against the glutamate. So we targeting the GABA, we enhance the GABA so that patient will relax, the brain will relax. So the neurotransmitter at work is GABA, not glutamate. Then patient will be sedated, calm. So you can proceed with your CMR or whatever procedure you want to do. Alright, so that is propofol. Propofol is what color? Oh, simple soalan. Propofol is what color, Atira Rahim? Dah sebut dah putih Okay lah. Contraindication of propofol at least, Barati?
Egg allergy, doctor.
Egg allergy, egg or soy, because it's made of egg and soy. Alright, very good, Barati. And then, what is the complication of using propofol? Iza Suhaimi? Tak ada. Dr. Yusri? Dr. Yusri ada ke? Propofol. Okay. Ada siapa-siapa nak jawab? Kiki? Oh, dia hapus tak Just a complication of propofol that you have to be careful lah. Anyone? Hello? Sri Pentas menunggu? Audience di rumah? Sashi? Dr. Iqbal?
Propofol infusion syndrome.
Oh, excellent, Dr. Iqbal. See, how experienced have made your MOs kan. So Dr. Iqbal betul. Memang kalau if it's using for so long, they can cause propofol infusion syndrome. So in the short term, the use in ED, we will worry of hypotension as well lah. Alright. Next, ketamine. Nah, ketamine ni pun famous juga kan. Selalu kita order. So, Husni, how ketamine work, Husni? Dr. Husni. Hello? Dr. Iwan? Dr. Yingyi?
NDMA.
Oral set ni siapa ni? Oral set.
Sihat.
Oral chat. Siapa ni?
Sihat.
Tak dengar siapa? Sekejap. Okey, tenang
Ahmad
semua.
Sihan.
Okey, tenang. Saya tak start lagi pun saya punya presentation. Come again, oral chat. Siapa tadi?
Sihat.
Siapa? Tak dengar.
Sihat.
Syihan. So jawapan dia apa tadi, Dr. Syihan?
Apa dia soalan dia?
Letak je nama pelik-pelik Syihan. Degil lah budak ni. Nama games ke apa ni? Syihan, macam mana ketamine punya mekanism?
Dia act on NDMA receptors.
Superb, excellent. So betul, actually they act at 5 places tau. NS-COM, mnemonic dia. So NS-COM. So they act dekat NMDA, they act dekat serotonin, they act dekat calcium channel, opioid receptor dengan muscarinic. So ni semua tempat yang dia act lah. So ketamine ni, so we have to be, saya jawab je lah mostly ya. So ketamine ni kita kena careful because of secretion lah. The tendency of patient will develop secretion. So suction is paramount jugalah, airway. And then it's a very good agent to use lah. And then dia ada kita panggil emergency phenomenon. There's a lot more lah complication I have to know. At least you know that secretion lah important while you doing the PSA. And then we have M. M is midazolam. Midazolam is very common as well kan. Sikit-sikit mida kan. City brain tak ada nak buat kan. Mida kan. So how does it work? Dr. Afif Nuha. Come on everyone. Dr. Iqbal jawab. Dr. Syihan jawab. Saya nak bagi dia interaktif sikit. Kalau tidak saya cakap dengan screen monitor je. Dr. Chiang nak cuba ke? Our budding master student. Midazolam. No response kan? So Mida sama juga dia add dekat GABA. So again be careful of hypotension lah. So there's a lot more detail lah for you to read lah afterwards But at least you know the agent that you use, what thing that you should be aware, how does it work. Next, kita go to second drugs. Okay, so the analgesia that we have first. We start from below lah, PCM. This one kau tak jawab memang nak kena pukul lah. Dr. Hassan, PCM macam mana dia work Dr. Hassan? Oh tengah patient BID. Okay. Dr. Sineha, PCM, how does it work Dr. Sineha? Simple paracetamol kan, senang-senang yang order kan. Dr. Atira, Dr. Afif Nuha, Dr. Sasi, paracetamol. Ada tak siapa-siapa nak jawab? Dr. Izzah, Dr. Janice. Hello, tak ada Dr. Mimah nak cuba ke? Dr. Mimah dekat depan saya. PCM, how does it work? Actually, the point is bukan saya nak, my point is not to say that how bad we are, we didn't know the mechanism. No, it's actually for us to remind ourselves lah. Nak bagi drugs tu kita kena betul-betul tahu juga drugs tu. Liver disease pun bagi je PCM. Betul lah. Okay? So PCM acts kat mana? Dia inhibit. Okay, so kita ada arachidonic acid punya cycle kan. Dia ada satu dia punya branching jadi leukotriene, jadi prostaglandin kan. So ada satu enzim nama dia COX. So COX enzyme tu cyclooxygenase. Dia inhibit yang tu. So sama lah actually all the celecoxib Voltaren ni pun dia akan inhibit there. Cumanya celecoxib dengan paracoxib ni dia lagi bagus. Dia selective of COX-1 ini COX-2 tu. Itu saja. And then morphine dengan fentanyl. Ni kalau tak boleh jawab juga nak kena pukul juga. Dr. Syah jawab dah, Iqbal jawab dah. Dr. Jensiang. Jensiang. Oh, tu dah jual tadi kan. Siapa yang tak participate ni? Dr. Afif Nuha, Dr. Hassan. Apa?
Opiate receptor.
Very good. So opiate receptor ada 3 lah, mu, kappa, delta. So you can tengok lah mana yang dia act more. Some drug dia act more on mu, some more on kappa. So every receptor tu akan ada different effect . So patient morphine, kalau dia act dekat, kata saya mu, dia akan analgesia lah, so dia boleh maintain. Dan kalau dia ada act on kappa dengan delta, dia boleh effect dia punya apa? Semualah BP, so kena monitor lah benda-benda kita bagi. Okay? Dia akan cause addiction juga, so kena careful. So yang hard, so that's the initial lah, bukan rimah ni actually. Kita nak warm up. Next, saya nak share something juga. I know nowadays kan, people watching a lot of, been watching a lot of shows kan. So dah tengok lah cerita ni kat Netflix, Thai King Rescue? Belum? Ataupun yang belah kanan sini ada 30 Life movie dia punya actor dia Colin Farrell dengan Viggo Mortensen. Tengok kat Amazon Prime lah kalau nak tengok. The reason saya share ni, nampak tak gua ni, gua Tam Luang ni, you see the geography kan, naik turun kan, very bad right, very difficult lah. So memang you perlukan specialist in cave diving to rescue lah. So Dr. Harry ni daripada Aussie, dia adalah anesthetist and happen to be world renowned cave diver. So lepas ni boleh lah nak belajar cave diving kan, nak belajar cave diving, kita ni pun tak tahu macam nak act kan, tak boleh lah. So kena tahu lah apa kita kena tahu, we have to be pro in our part lah. So you see how they rescue, they're the first diver and second diver kan. So they have to mounted another oxygen tank to the diver, and this line, the rescue line that they use was placed not by the Navy SEAL of Thai because it's very difficult. Navy SEAL mati seorang. The cave diver set up the line for 4 kilometers. That's how deep is the cave. One child to bring out take 5 hours. And how do you bring a child at age of 8, 10 years old throughout the water for 4 kilometers? It's impossible, right? So this is one of the best rescue mission in the world at the moment lah, to the record of history. So how do you do it? Okay, itu entertainment aside lah. The point is, nampak tak budak ni dia pakai satu mask. The mask that they use is not a snorkeling mask yang you pakai dekat Pulau Perhentian. It's actually a positive pressure mask. Macam you punya CPAP. That kind of mask that they use for the child. Sebab bila you sedate patient tak boleh breathe normally kan. Dia kena regulator untuk regulate air in, air out for the child. So diver tu, while rescuing, holding the child, holding the wire, they have to press the regulator for the child to breathe. Okay, and what sedation they select? There's a good discussion on this drama series as well. How doctors in Thailand disagree on the agent to use. Until Dr. Harry insists, if you want me to do it, you have to listen to me. And you have to give me immunity lah. Kalau child mati, jangan masuk sel penjara lah. Because I'm trying to help. Until in the end, they agree to use which agent? Siapa yang dah watch this movie? They use ketamine. So interesting, right? So asyik tengok cerita Korea je kan. So watch something yang medical based kan. Barulah kita open minded sikit. Now we know, oh, this thing can be applied in even rescue. Tapi saya tak ada lah cave diving rescue kan. Sekat boleh berenang kolam boleh lah kan. So everybody have to know lah. If you have a set of skill, you will be needed lah. Even giving ketamine is a skill juga. Alright? Okay, next. Banyak pula selingan kan. Now baru kita go to the serious matter of the PSA. So PSA ni what is our goal? So our goal is not to make us calm. It's actually to maintain the priority of a patient safety. Whatever you want to do, whatever drug you want to give, whatever procedure you want to proceed, patient safety comes first. Alright. And number 2, our aim is to minimize the pain and anxiety. Because pain and anxiety, if you don't optimize the pain control, patient will be anxious. So CMR will fail. You will try to pull all the limbs, patient will resist because of the pain. Alright? And then we want to minimize the patient motion. So patient restless, you cannot do CMR. Patient will resist you. Okay? And we want to maximize the chance of success of the procedure. So this is our goal. Our goal in mind. Oh, PSA, these are our 4 goals. 1, 2, 3. 4, okay lah kan. So our bite-sized information that we have to remember. This is the goal. Alright? Next, when we perform, so a healthcare personnel should be professional. We still have to be professional. We have to be sensitive to patient pain and patient care. Patient vital signs have to be thorough in what we're doing. We have to be gentle, thoughtful, and efficient. So when we use sedative for sedation and opiate for analgesia for pain control, so we need to know there's a specific reversal agent that are available. What agent that we have, Dr. Dr. Sasi, do you know any agent that can reverse any drug that we use in PSA? Sasi kerja Dr. Husni? Dr. Sasi? Come.
Ada.
Apa tu Dr. Sasi yang you tahu?
Mida.
Mida guna apa reversal?
Tanya pula.
Guna apa Sasi? Reversal Mida. Boleh Google. Saya tak blame. Boleh Google. Dunia sekarang kita allow Google. Siapa nak bantu ke? Bantu Dr. Sasi?
Flumazenil.
Very good. Okay, kalau opioid Sasi, apa pula reversal? Opioid. Anyone else? Reversal for opioid? Sasi?
Naloxone.
Dr. Kiki jawab Okay, Dr. Kiki bantu So it's a flumazenil lah. Alright. So who needs PSA? Do everyone need PSA? Do Faiz here need PSA because he seems so sleepy? No, right? So we need to identify people and patients that require PSA. So patients who need PSA, it depends on there are few stages that we can identify. First, examination process. MVA patient came in with all the deformity. You don't do lock roll and everything first without giving analgesia. Be human. Give analgesia. ATT, fentanyl, then you proceed with all the full examination. Okay? Just because you want to get our job done, we want to be thorough, but we forget about the pain analgesia. Next, diagnostic process. Some procedure does cause pain lah. Okay? For example, we maneuvering the body part. You're doing log roll, you are pulling the lower limb that is deformed from crush injury. So you have to consider patient in pain. So this can also involve the use of PSA, right? And therapeutic process. These are the common procedures that you know, all the CMR, suturing, wound dressing, all the injections. Sometimes you can give PSA. PSA doesn't just include all the agents that I said. Even LA is a part of PSA actually. Okay? And how to do it? So how to do it? When it's a procedure, we will divide it into a before, during, and after. So it's a timeline. So it's like you know when you're on a plane. So you're a pilot. You want to bring the plane up, and you want to stabilize it, and you want to bring the plane down. I want to land properly. So that's the same as the procedure. You're the one in charge of the procedure. The procedure for CMR, we let it to auto to do it, but we assist on this flight for the patient. Okay? So pre-procedure, before the procedure, what do we need to do? We need to establish a plan. Alright? Because the procedure will likely to produce pain and anxiety. Select the appropriate pharmacological agent that you want to use. How do you want to select? Just now we already revised, right? Procatab, all the fentanyl, opioid, morphine. How does it work? What are the complications? And the contraindication, they have to be careful. So if you're able to identify all this, you can select the agent wisely. Alright? And then non-pharmacological intervention. So non-pharmacological intervention is also working apart from giving a medication. CMR, sometimes you reduce the deformity very quickly, so that also will reduce the pain appropriately. And then we need to develop a plan. A plan if deterioration happen. If elderly patient develop respiratory distress, hypotension, how are we going to overcome? So we have to have plan. So before we start anything, we have to plan. So it's respiratory distress, then baru kita kalau nak cari status, ambil SpO2 monitor, so you cannot do that, okay? And then baru nak pasang BP cuff, so this is thing that will done without plan, so you have to plan, okay? Alright, and then consider the procedural sedation if the procedure is to be significantly painful, like CMR is very, very painful, cannot be done without PSA. Immobility of the patient is required for a longer period of time. A procedure that will take longer than 5 minutes, so it's important for you to use PSA. And then even if patient express great concern and distress thinking of being awake during the procedure, so we have to consider the depth of sedation that we want to provide to this patient. Okay, these are all the strategy. This is still before our strategy. Okay, if the PSA is the best interest and patient cannot be administered in the current setting, consider transfer to a location for administration of the PSA. So we don't do it in green zone. It's not comfortable to do that. I mean, yellow and red is a better place to do CMR. So given our current in lights of event, we have still COVID-19 punya procedure. So we don't go to red zone. You can come to yellow zone. We have all the monitors and you can apply them prior to the PSA. So consider the preemptive analgesia. So we can still give fentanyl prior to start of the PSA. It's okay as long as not overdose. All right. Apart from that, what else we have to do it before? Apart from planning, you have to prepare. So what you want to prepare? Prepare mental because kita nak bagi drugs, is it? So we have to prepare everything. So we prepare the patient condition, the vital sign, explain the patient properly, what is the procedure we're giving, and then is there any allergy? Allergy, don't forget. So allergy, sometimes you forget about allergy, you just give, and then suddenly patient already in anaphylactic shock. So you have to be careful on that. And pain score target that we want. So it should be less than 4. And then patient's right to request for additional pain relief. So we know if patient stay in pain, they say, so you reassess the pain score. The pain score still high, you can add up other modalities of analgesia. Acknowledge the patient fear and concern. So sometimes there are cases where pain optimization in ED is suboptimal because of kita punya judgmental views of the healthcare worker. Oh, tak ada apa ni, sakit sikit je dah bagi dah ni fentanyl. Sometimes it's just people's pain score, patient pain tolerance is different. So we have to listen to what our patient is telling us. Okay, all right, and get an obtain written consent. So consent is important. Do not do PSA without consent. Okay, anything that we do, we have to be able to get the consent from the appropriate person. If the patient is above 18 and have augmented capacity, get from the patient. If it's less than 18, it's a children, get from the legal guardian, the parent. Okay. And then patient agree on optimal patient's condition and ensure the medication that administered to allow sufficient time of effectiveness before the procedure. So these are the before consideration. And then what else want to prepare? Prepare your healthcare team. PSA, I notice what we apply here, we tend to let one doctors, MOs, to give the medication, while our staff diluted and then give the drugs to us. Sometimes the labeling is only fentanyl. We don't even know one meal equals to how many mic. You know what I'm trying to imply. Once our staff nurse diluted and passed to us, we only trust whatever is labeled there, probably 1 mg per meal, but it's actually ketamine, will be very risky. Some people they dilute ketamine, some do not. Sometimes ketamine to 1 meal could be equal to 1 mg. Sometimes it can be 1 meal equal to 10 mg. So that's the danger come. That's what I noticed lah. That's what I noticed. So it's actually best for PSA. We assign 1 MO, we assign 1 staff nurse to help at the site as well. Because the staff nurse that diluted the drug should be there with us. I know it's difficult. Sometimes yellow zone will be overwhelmed with patient. We don't have much patient. Sometimes we're too busy ortho bugging us for the PSA, but it's still our responsibility. We still have to work on it. Okay? There are some dangers and caveat that we notice. Even more dangerous, sometimes our MO pass the PSA form, printed the PSA form, and give it to ortho, give the drug to ortho. Even more dangerous. Alright? PSA is emergency responsibility. It's not ortho responsibilities. We are used to the medication better than they are. Okay, kalau you tanya the same question back to ortho, I bet they can answer you how MIDA works. So I think at least emergency doctors know better. Alright, so PSA is ED responsibility, not ortho. Do not pass the PSA form and the drugs to MO ortho. Okay, alright. And then the procedure specific, so you have to prime your team, your staff nurse, what we're going to do, how much we're going to give first, the medications, what we're going to monitor, the SpO2, the BP, okay? And then identify someone to lead the distraction and coping technique. Sometimes we can talk to patient before the sedation works, right? Try to distract the patient. And then know how often the procedure will need to be repeated. Okay, sometimes we have to repeat the dose if it's not enough for the sedation. So apart from that, we still in the before time of the timeline. So what else we want to prepare? So we want to assess the patient ASA status. What is ASA? So ASA is, the answer is there. It's an American Society of Anesthesia. Previously, PSA was done by anesthetists, but now because actually NS is like our twin sister or twin brother. So we are the late twin that come out lah. Tak aku. Oh, gaduh. gaduh. So we are distant cousin to NS lah, distant cousin. Boleh ya? Distant cousin. They disagree when I say it's a twin. So it's a distant cousin. So NS is our distant cousin. Previously it was administered by them only. If you look for the CPG, or if you googling around, the initial CPG that came up is by NS in 2013 or 2012. It's a very old CPG. But we have come up with our own in 2020 by ED, by Emergency Physician College. Okay? So ASA is how we at least re-stratify our patient. So we can divide them into class 1, 2, 3, 4, and 5. So 1 is a normal healthy patient, 2 is a mild systemic disease, 3 is a severe systemic disease but not incapacitating, 4 is a incapacitating severe systemic disease, number 5 is a moribund patient, not expect to survive for 24 hours. Alright, so what has been decided in emergency medicine, in emergency CPGs, ASA 1 and 2 can be performed in emergency department. If it's beyond that, they will need to refer to NS to be done in OT settings. Meaning the risk is too high for us to do it in our area, okay, in our clinical area. So ASA important. So after this, try document the ASA before the procedure so that we can re-certify the patient. All right, next. So we move from our timeline just now, from before to during now. So for during, again, I would like to emphasize the same thing. Continuous monitoring of pulse rate and O2 saturation and regular monitoring on depth of sedation. Another mistake that we used to do, we didn't apply all the monitors, number one. Or if you apply, we don't prepare with nasal prong oxygen if it's indicated. Bila patient dah discharge, baru kelang kabut nak cari Thanas, can you pick nasal prong? There's nothing wrong to get the nasal prong, tapi buka lagi letak sebelah back the patient dengan you. Once you need it, just bagi oxygen, okay? And then another thing is, I noticed that the depth of sedation is not being supervised by us. We give the medication, we leave ortho to do the CMR. We just hope that the patient is deeply sedated. We don't even know is it sufficient or is it too deep of sedation. So EMO has to be there, standing there, charting the vital signs of the pre-procedure, during procedure, and after procedure, and also the depth of sedation. It's very important. Sometimes we too busy, and then we just hope that the sedation is just enough. So it's wrong.
Okay, just nak tambah Razi punya, as mentioned by Razi lah, MO yang in charge nak bagi PSA have to be there to monitor the patient. Secondly, with regards to monitoring, everyone needs to be familiar with whatever monitor yang kita ada lah. Ni untuk memudahkan kerja anda-anda semua. Belajarlah tekan interval dekat monitor tu, set auto every 5 minutes ke. It will save you a lot of time dan it will help you to avoid forgetting to tekan lah. Kan nak kena dokumen BP, SpO2 during pre, during and after. Kalau korang buat auto interval macam BP tu auto interval every 5 minutes ke, even if you forget to check at the time, you can always check dekat trends later. So try lah godek-godek korang punya monitor tu. Takut sangat, bukan, the monitor is not exclusively untuk staff nurse sahaja untuk pegang dan tekan. We got so many monitors kan, daripada Nihon Koden kepada I don't know what, Panasonic ke apa ke, you know, Zoll dan sebagainya. Belajarlah tekan button tu. Tak rosak. Kalau rosak pun jangan mengaku je lah. So you know, taklah. I mean setakat kalau tekan-tekan button tu tak rosak lah. Learn how to set auto interval for each monitor. Especially important if macam bila PSA kan, kadang-kadang monitor duduk kat hujung sana, lepas tu auto duduk tarik sini, you can't even reach nak tekan kan, nak tekan BP ke dan sebagainya. So if you set auto interval, saves you a lot of trouble. Sama juga bila hantar patient pergi CT scan. Kan, kalau korang buat manual, takkanlah masa CT scan tu tengah duduk berjalan, korang nak masuk tekan pula. Set auto interval je. And then dah habis, snap lah gambar trends tu. So nanti tulis lah. Kan, because you know, phone semua bawa. Phone ada kamera. You know, make use of, you know, whatever that you have to make your life easier lah. Kan. Okay, tu je lah. Pegang monitor masing-masing.
I agree actually. So sebab macam technology is very good nowadays kan. It's easy for us to do the monitoring kan. So play around with the machines lah. Jangan jadi macam saya jugalah. Masa nak guna Copilot tu cari button on pun tak jumpa. Because that's why important for you to know your device, your machines, your monitoring kan. So kena banyak-banyak pegang. Okay?
Belum dalam nak guna tu dah kena pegang lah. Masa dah PCR baru nak cari button on tu dah lah.
Betul. Patutnya dah kena biasa dah dengan machine tu. So I agree. So for PSA same thing. Learn to know your monitor. Tak tahu tanya misi, dia orang tahu boleh bagi tahu button mana. Different machine, different style of handling dia kan. Alright, again, just continue apart from the monitoring. So trained personnel must be present, must be present. So tak boleh lah bagi PSA and gone you are looking at the new case. Sometimes you're busy but you cannot because this is sedation that we're giving. And this is not just normal saline. You're giving sedation, so you have to be and present at the procedure time. All right, next, supplemental oxygen have to be administered. So at least get a nasal prong into the patient. Although the SpO2 is 95, you don't want to be running around when the SpO2 is at 88. So you don't want. So at least be prepared. This is a procedure. Again, you the pilot. You the pilot. You want the flight to go. To depart well and to land well, right? So you are the one is the pilot of the procedure. Ortho, they do the procedure. We in charge of the sedation and analgesia. All right, remember that. So the monitoring must be continued into recovery phase. So it's not until ortho done with their POP, their CMR. You have to wait until patient wake up, because until the end, you have to wait until the sedation wear off. And then pain or anxiety are not well controlled during the procedure. Ask the healthcare provider performing the procedure to stop. Allow for further evaluation to be conducted and need for additional support. So jangan takut dengan ortho. Bagi tahu dia, tunggu sekejap. I think this one nak betul-betul optimize lagi dia punya PSA. Once it's okay, I let you know when to do it. Okay? So you are in charge. So you don't have to be scared of other team. Okay? We work in team. So we still have the say, the decision comes from us. All right. So how deep is your sedation? How do we analyze how deep is your sedation? Okay, actually, if we go through, Titinalis or other reference, there are a few a scoring system or the scale that we can use. They call it as a RAS, RASS dengan RAS kan. So RASS is a Richmond Agitation Sedation Scale. Okay, another one is RAS is Ramsey agitation scale. So it's actually similar thing. Cumanya when they study this, some is better than one other. The concept is the same. So our CPG, the Malaysian CPG, came up with this, the continuum of depth sedation. So again, we divide into mild, moderate, deep, and GA. So mild, moderate, deep sedation, and GA. And how do we measure? We measure the responsiveness, airway, spontaneous ventilation, and cardiovascular function. So we have to see, for example, responsiveness. If it's only minimal sedation, we will still be able to have a normal response to verbal stimulation. Adik buka mata, patient still boleh, dia still boleh respond dengan you. Verbally pun dia boleh respond. Kalau moderate, dia akan ada purposeful response to verbal and tactile stimulation. And if it's deep, there's a purposeful response after repeated painful stimuli. Itu deep, okay? Panggil tak respond, pain baru respond, so he's deep, okay? GA unarousable lah. Patient in OT wouldn't be arousable during the procedure. Airway, we look at the minimal sedation. You know, when you use a minimal sedation, airway won't be affected as much. But if you go for a moderate, still there's no intervention required. But if it's too deep of the sedation, intervention may be required. So we have to be careful. When patient too deeply sedated, you might have to intubate the patient because of the airway. It's not that patent anymore. Alright, the GA part I won't comment lah. That is the OT part. So it's still in the scale. Spontaneous ventilation. So you have to see, when you use a minimal sedation, likelihood of the ventilation being impaired is very low, so it's unaffected. But for a moderate sedation, patient can still have adequate ventilation. And then in the Thai rescue one just now, they use the ketamine into a moderate sedation. But one child almost have a very deep sedation, and they might have lose the child. They cannot intubate in the cave. Just to know, just a fun fact. Deep sedation. Maybe inadequate for the spontaneous ventilation. You may have to consider for intubation. Cardiovascular function, mild sedation, minimal sedation, unaffected. And then for moderate sedation, usually maintained. And deep sedation, usually maintained as well. So these are the scale that you can use, RAS scale. It's not hidden anywhere. You can Google the PSA CPG and save it into your phone. And you can always refer to it if you don't remember. Okay? Next. So we were before, during, and after. Panjangan dia punya timeline kan. Before, during, now we are in after. So the after procedure, how are we going to do it? So after the procedure is completed, we continue to monitor the vital sign. So if opiate being used, patient need to be observed until patient regain full consciousness. Then, if we know it's not regaining the full consciousness, we may consider reversal lah. Sometimes we have to be careful. When we reverse the opiate, suddenly patient might be in severe pain as well. So we have to be thorough and be wise in your judgment as well, your clinical judgment. Next, we have to develop and implement a comfort management plan after the procedure. Okay, janganlah patient after CMR you put on a chair. You make sure there's a stretcher, make sure patient comfortable, ada oxygen semua. Janganlah pergi letak dekat tengah-tengah green zone pula. Green zone tu adalah tempat yang busy kan. So letak in the green, yellow zone, continue monitoring there. And then multimodal pharmacology. Sometimes you give fentanyl and we hope it works. Sometimes it might not be enough. So we have to look at other modalities of analgesia. So if you are unsure, you can ask your senior MOs. You can ask your EPs as well. Right? And then the comfort plan should include care in the event of patient no longer in the healthcare setting. So meaning after the procedure, sometimes we discharge the patient, right? Dah lah fracture here and there, discharge PCM. You know already is inadequate for a PCM only kan. So these are the modality as well. NSAIDs and opioid. Sometimes like opioid like trauma kan, or oral opioid that we can use. So these are among the consideration that you can think of the analgesia of choice. And then patient must be discharged into the care of a responsible adult who may be given written instruction. So patient that you want discharge, 7 years old, 8 years old, it has to be discharged to a responsible adult, their parents especially. So you have to explain to parent what kind of thing to monitor. Once the patient well, then they can eat, etc. And if the patient is not improved, they have to bring back the emergency. So a responsible adult is important as well. Okay. And refer letter to respective department and nearest clinic as appropriate. This one, I mean, not much that we can do. We can do referral letters and etc. Sometimes we were able to reduce all the dislocation on our own prior to arrival. Sometimes we have to refer them for an outpatient clinic as well. So these are things that we want to assist patient apart from just doing the PSA. Oh, kenapa dia keluar? Sekejap lama sangat kot. Semua orang dah lapar. Sekejap dia slow sikit. Any role of giving
Any role of giving antidote immediately after the procedure finish sebab
any
kau
role
just
of
wait.
giving. Kalau you nak bagi as a compulsory administration, we don't apply that lah. But if patient does not reverted from the deep sedation tu, we may consider the reversal. But we don't use it as a routine. So beli dah iPad baru sebenarnya. Tapi tak ada dongle. Beli dah tu. iPad dah lama ni. iPad ni saya pergi Jogja Dr. Mashi dulu ni. Dan memang kena retire dah iPad ni sebenarnya. Tak ada iPad Dr. Mashi, iPad. Bukan Dr. Mashi. Mana Dr. Mashi? Okay, kat mana kita tadi? Sorry iPad ni dia crash sikit dia tak guna chip yang latest. So documentation. So I cannot stress more on documentation lah. It's very important. I mean credits to Dr. Rohayu and Dr. Mashi. They come up with a better documentation wise in our EEs. We have our own form kan. Do you all aware of the PSA procedural form? Kalau tak tahu tu Dr. Rohayu boleh ketuk kepala. Siapa yang tak tahu? It has been there prior to me going to master. It must be at least 5 years. 4 years 4 years I think. Dr. Rohayu printed some more for audience here. So documentation, name of staff in charge, history, examination and procedure that we do, the dosage of drug that we use, the vital sign, pre, intra and post procedure. So everything that I've said is already essentially in the form. It was beautifully summarized in the form. Okay. Nanti saya show juga example form Dr. Rohayu. Okay, just basically that is PSA. In summary that is PSA. So just to cover some examples of procedure that can be done in emergency that require PSA. For example, the first one is CMR lah here. CMR for fracture or dislocation. So we know the management sometimes the initial management from triage is actually we can elevate, splinting, ice, rise kan in management. And then kita assess this patient if we decided that there's a procedure have to be done and then we might have to do a PSA. So the CPG even came up with the suggested agent that we can use. That's how beautiful our CPG is actually. It summarizes everything. The issue is not with the CPG. The issue with us. We are not reading the CPG. Alright? So for analgesia technique that they suggested, okay, positioning, distraction, relaxation, and other coping strategy. And then they can even advise LA with or without sedation. If it's very severe fracture, you can consider analgesia without sedation, which is fentanyl and morphine lah. Analgesia sahaja, tak ada sedation function. Some, they will suggest analgesia with sedation. So sedation yang ada ketamine with or without MIDA, or fentanyl and propofol, or fentanyl and MIDA. So there are a mixture of drugs that you can use as advised by the CPG. Alright. Next, chest tube insertion and CVL insertion. Ini kan selalu Dr. Beh dengan Dr. Bila suka ni, dia orang jonah kan selalu. Razi insert chest tube, prepare Mimah untuk CVL insertion. Kan? These two person memang jonah. I have to tell you. CVL and CVP, dia orang dua ni cukup banyak. Dr. Anas pun ni dah macam mula dah menjorai carta CVL kan. ni orang-orang yang jonah lah, jonah CVL kan. Okay? So impose,
Don't
be
jinx
aware,
my
be aware.
call.
Biar marah apa Beh?
Don't jinx my call. I'm on call today.
Beh kata dia on call hari ni. Dia takut saya jinx on call dia. Pray hard lah, whoever working today. Lawak Beh. Alright, so for chest tube, again, you have to know that I think most of MO are aware of using of LA. We use LA, of course, but sometimes you forgot about giving another analgesia. It's a very painful for you to be wiggling the ribs and the intercostal muscle. In fact, every rib have a nerve of their own, so it's very important for us to remember that. So again, the technique that they suggest: positioning, distraction, relaxation, and other coping strategies. So we can consider IV analgesia and local analgesia. See, so we can use morphine, fentanyl, and then we can use an analgesic dose of ketamine. Here the dose as well. And then there's also is a good alternative from opioid. We can use ketamine. And for LA, we can titrate up to 5 mg per kilo of lidocaine, either 1% or 2%. Alright, intercostal block can also be considered. So we rarely do intercostal block, but we can actually perform by ultrasound guided if you are capable enough lah. I think Shihan maybe know how to do it. Shihan dia banyak pergi course ultrasound, so ada possibility dia boleh buat. Alright, okay, next. Another example, suturing of laceration wound. So they even describe what kind of analgesia that we can use. For this one, for local analgesia, we can titrate up to 5 mg per kilo. So the CPG is quite nice actually. It covers very detail of pain management and PSE. Then ureteral catheterization. So catheter insertion is actually painful. Although saya tak pernah pun kena, tapi still we have to digest that, because sometimes we forget. We just order CBD kat CBD when we don't know the patient is in pain. So make sure our staff when they insert they use topical lidocaine lubricant. Bukannya KY jelly. And then satu lagi issues, I think Dr. Zainal pun ada highlight. Every one of us need to monitor, make sure that CBD insertion is being done sterile. Sometimes when they want to do it fast, so they compromise on the sterility of the procedure and also the topical lidocaine usage. So I think if we ourselves don't want to get UTI from the CBD insertion, right? So we at least try to monitor lah. We have to monitor. Sometimes we didn't notice because it's behind the curtain. We were too busy. So everybody maybe have to be a bit more, I say, more considerate and hypervigilant lah. More humane lah, more humane. CBD insertion without sterility, without topical lidocaine is inhuman actually. The simple words. Careful lah. A simple procedure, very painful, can lead to sepsis juga kalau you tak do it in sterile. Next, cardioverse and pacing. Okay, cardioverse and pacing, again we follow the SAS guideline. Let's say we decided, we need to cardioverse this patient or we need to pace this patient. Think of sedation and analgesia as well. Alright. So what did they suggest here? Ketamine with or without midazolam, fentanyl and midazolam, fentanyl and propofol. So they suggest the agents to us. It's up to us to follow, or you are more comfortable and confident in using the PSA agent, you can decide whichever agent you are like to. Next, this is the table and drugs and reference and doses that they share in the CPG. So it's go back to our propofol, right? Propofol, ketamine, mida, right? This is sedation and analgesia, and fentanyl is the analgesia, the opioid analgesia. So you can have the dose, 1 to 2 mic, okay? Midazolam 0.02, 0.03. Per mg per kilo, and also propofol 1 mg per kilo, ketamine 1 mg per kilo. So it's quite actually not difficult to memorize the doses sebenarnya, but you have to make sure you give the correct dose. Okay, so this is the dosage. You can refer later on the reference. What is this? Our old friend from medical school, Dr. Faiz, Dr. Hamis lah, Dr. Hamis. Dr. Hamis ni apa, Dr. Hamis? Kan? WHO, analgesic ladder lah kan, analgesic pain kan, so analgesic ladder, memang ada jawapan sini, tapi actually it's a WHO so idea asal is actually from WHO, so they have developed this kind of approach, I think since our medical school years probably a decade or more than a decade ago. So we have a mild, moderate, and severe and uncontrolled pain. So scoring system 1 to 3, pain score 4 to 6, 7 to 10. So we have, so first step mild, we go to agent then other than opioid first. So you can go to PCM, you can go NSAID, we follow at the COX punya systems, the arachidonic acid. If it's not appropriate, it's not enough, then we may consider weak opioid like tramadol. Okay? If it's still not controlled, then we consider strong opioid like morphine. If it's not well controlled, the pain, then we can refer to APS. Do we have APS in HSAH? The answer is we do. We do have APS. Okay? Next, this is a morphine pain protocol. We have to later we have to look for the HSAH, the protocol lah. This is just something that they share in the CPG. It was shared from Royal Adelaide Hospital, so it was based on that lah. So you have to look at the pain score. Either you need to give opioid, and if it's not improving, do we add another more based on the sedation score? Is it too sedated? So it's dangerous, especially very deeply sedated. You want to give another opioid, so you have to consult when you're unsure. So these are the guidelines that they have come up in Royal Adelaide Hospital in Aussie. They've been shared in the CPG. So it will be good if we were able to get our hand into our HSAH guideline, our local protocol, if there is available from NS.
Just nak tambah pasal morfin ni lah. Juga nak remind kita semua lah. Janganlah takut sangat nak start morfin. Kalau pain score tu kaki dia dah putus ke, dah, janganlah start dah bagi painkiller, bagi Voltaren. Ya Allah, sedihnya. Bagilah morfin. Bagi 1 mg, 2 mg and titrate. The thing is, it's not dangerous if you titrate. You don't give 5-10 mg, you give 2 mg, then titrate according to patient response. So kadang-kadang sedih tengok patient open fracture femur, kadang pelvic injury, painkiller bagi apa? Bagi Voltaren. Kadang-kadang patient macam tu terus start dengan something yang up lah, not trauma, just go fentanyl, morphine dan sebagainya. Morphine, it's not something, IV morphine, it's not that dangerous if you monitor the patient and you give in titrating dose. Okay, fikir macam tu je lah. Just imagine yourself open fracture femur, dan adalah makhluk ni cucuk IM diclofenac. Tak kesedih ke? Dah lah sakit kaki, sakit hati pula kan. Macam, menambah pain score dia. So, tapi be aware, if you pain score, so even dalam WHO punya whatever pain ladder dan sebagainya, pain score more than 7 tu dah indicated untuk opioid dah. Bukan, your simple analgesia dah. Okay, just, case by case basis. Cuba kikis benda-benda tradisi yang telah tertanam semasa houseman 2 tahun ke, ataupun our, practice yang kita bawa daripada generasi-generasi sebelum ni. Ada anjakan paradigma, do something properly lah. Okay, especially pain. And this is usually a source of complaint dan ketidakpuasan hati lah. Dia datang sakit, kita tak address sakit dia. Kita sibuk lah dengan ECG changes, dengan electrolyte imbalance. Dia duduk sakit lagi. Kan? So, sometimes benda-benda simple je. Kan? Okay.
Dengar kan audience kat rumah kan, Dr. Fairuz punya input tadi. Hilang pula. Boleh dengar kan Dr. Fairuz cakap tadi kan? Dengar kan? Ke tak dengar? Dengar lah kot. Okay, Dr. Ben kat tengah. Alright, so next, I just share HSAH lah, how we do it kan. Dr. Rohayu did printed the version of this as well lah. So I just snap this from his lah. So you all familiar with this, right? So PSA punya form. So kita ada pre-procedure, during procedure and post-procedure lah of the vitals, BP, pulse semua. So we need to chart this lah. And then the drug use that we use lah, fentanyl ke, morphine ke, opioid ke, propofol ke, ketamine ke, semua you kena document lah all the dosage that you use in total and route that you use lah, mostly IV kan. Okay, yang thigh cave tu dia guna IM ketamine lah, right into the thigh. Okay, next kita banyak-banyak kan diselingan. Sorry, saya memang biasalah short attention span kan. So kita punya consent pun ada kat bawah ni. So make sure get the consent properly. I have seen cases we printed without consent. we just do without consent. So tak nak lah, kena make sure ada consent lah. Get the patient sign. So atas ni pun even bawah ni Dr. Rohayu ada siap list lagi. Hypotension, ada tak complication dia? Hypotension, respiratory depression, desaturation, need for intubation. So kita dah prepare dah sebenarnya benda-benda tu. Cuma kita tak never go look into it and properly kan. So sometimes we missed it lah. Okay? These are my reference lah. So reference wise, actually it's similar lah kalau you refer to Titinali pun. But I go very local. I go to our own management, our own CPG. Pain Management in ED Department, second edition 2020. Check by Dr. Sabari, I think. Dr. Arman semua involved jugalah. So maybe MOs can start Google di CPG. Nak Google Titinali pun boleh juga, simpan lah study. Tapi better study Pain Management dululah. Macam saya pesan kat MOs kan. It's too high expectation to expect people to cover Titinali. But if you cover CPG, you are set. You are set and safe. Alright, that's it for a long lecture on PSA, just a revision. That's it from me. Thank you very much. Any question? Dr. Ayu nak tambah sikit sekejap
Okay, thank you Dr. Razi. Okay, PSA very good presentation. So memang kalau ikut PSA ni memang kena buat yearly tu kena ada 2-3 kali jugalah kena buat, nak remind kat you all semua kan. Okay, so yang untuk PSA selalu kita buat yang the form untuk PSA tu just nak make meaning that kalau kata you nak buat keluar drug yang SDDA tu, you memang kena print out the form. Kan, print out the form tu lah. Cuma kita notice kat form ni selalunya apa ya dia tak complete. So apa yang tak complete selalunya tak ada documentation untuk pre-procedure, during procedure dengan post-procedure punya vital sign. So please make sure lepas ni memang you all semua kena bagi lah benda tu. Bukan kata form ni saya memang go through lah selalu. Memang yang tu akan tak complete. Lagi satu, PSA ni one of kita punya KPI dah. KPI. KPI kita lah. Yang monitor. Okay. So, KPI ni dia nak monitor the complication of the procedure. Okay. Complication of the procedure. Sebab tu kita list down kan. Kat belakang tu. Kat belakang tu dia ada complication tu. Cuma apa yang kita pasal you all macam takut nak letak. Kalau kata let's say patient ada hypotension, just stick hypotension. So tak kisah walaupun kita tak achieve dia punya target, tapi at least based on the documentation ni, based on the data ni, at least kita boleh improve. Okay? Kalau you tengok yang initially as 2015 dia punya dia punya aim adalah complication tu less than 10%. Tapi kalau latest now dia target less than 5%. Okay, kalau ikut yang latest punya pun dia dah allow untuk bukan ED saja sebenarnya bagi PSA. Ada team pun boleh bagi PSA, primary team. Tapi kita punya ED HSAH kita tak allow lagi lah. Sebab kita sendiri pun banyak lagi kita punya kelemahan tu. So kita nak make sure kita okay, baru kita boleh train other department. Okay. So kita still stick pada rule tu. Kalau you all nak buat PSA drug, you kena print this one, kena tunjuk kat staff ni untuk release the drug. Kalau yang diluted apa semua tu, nak dilute apa semua tu, yes. Memang kita kena dilute ataupun under observation kita. Okay. Sebab the primary team only do the procedure. Yang bagi drug tu is still the ED. Okay. After this saya minta semua bagi kerjasama untuk complete the form. Okay, setiap kali kita print out kita complete the form, and then kalau ada complication, no issue, you all boleh documented saja. Okay. Okay.
Also decide then there's some communication breakdown go back to our MO. So this auto MO bypass our ED MO order to our green zone staff lah. Dan bila prosedur yang dibuat, usually it is done either in the room, in yellow behind or in yellow kan. So siapa nak monitor, siapa nak bagi ubat
by right, the drug ni memang MO auto tak boleh order. Memang saya stress selalu kat sister, staff nurse hanya boleh release kat MO saja. MO pun not all MO. MOED. MOED yang quite senior juga. Selalunya kalau dah duduk kat ED tu lebih daripada 4 bulan, 6 bulan tu kita bagilah. Kalau too junior baru buat tagging apa semua, it's not allowed. Okay. Yang tu memang kita buat rules macam tu. Tapi saya tahu ada yang setengah tu dia bypass. Betul tak? Patient kat green, bypass, bagi kat staff nurse release kat auto. By right tak boleh. PSA memang should be done in yellow zone. Yellow zone atau red zone memang under full monitoring. And then yang boleh order only MO saja. MOED. MOED memang kena buat kat yellow under monitoring, and then only EDMO can request for the drug. Okay, PSA drug. Okay, yang tu untuk PSA. Tak boleh. Tak. You kena bagi tahu kot kat EP. Kadang kami pun terlepas pandang. Sebab kami boleh maybe yang tu kena bagi tahu kat EP. Lepas tu nanti maybe kita kena cakap dengan dia punya bos lah. Kan. Susah sebab yang tu kita boleh tegur directly, tapi at the same time kita boleh bagi tahu dia punya ada in-charge person kat sana lah. HOD dia.
Whatever happens in our department is our responsibility. So whatever that they bawa pun, tapi if you do not know kan, kita yang kena decide, kita yang kena. I think the PSA tinggi ni nampak simple kan, tapi sebenarnya kalau once ada complication, ada dia complication memang very big issue lah.
Sebab tu kena ada documentation tu very important lah. Selalunya dokumen tu kita lack of documentation. Another thing is pasal morphine. Okay, morphine macam Dr. Fairuz kata lah, memang kita takut kan nak guna morphine. Banyak yang takut nak guna morphine kan. So kalau ikut under yang kita ni sekarang ke arah pain free hospital. So bila pain free hospital ni dia banyak guna morphine. So lepas ni mungkin kita boleh biasakan dia guna morphine. And then the other thing, kalau you all kita guna morphine, please documented kita ada morphine protocol note. Ada morphine protocol notes Tahu tak? Mesti banyak orang ramai yang tak tahu kan. Morphine protocol notes So kalau start guna morphine boleh documented dalam tu. Nanti you all tengok dalam notes tu ada morphine protocol notes. So yang ni boleh di-review, maksudnya under pain free ni dia akan boleh review penggunaan morphine. So kalau kata kita guna tetapi kita tak documented kan. So nanti kalau go by department nampak kita ni antara yang tercorot lah. Padahal kita guna kan. So please make sure after this kalau kita give morphine to the patient, documented dalam morphine protocol notes tu. Okay. You tengok yang under generic tu lah, generic. Dia ada list tu lah. Go to morphine protocol.
Untuk PSA staff nurse, dia akan request sebenarnya kita yang minta, kita ni punya request one form of fee. So is it okay kalau kita print out and sign one? Maksudnya kita report dulu dan kita print out. Sebab kalau nak print out, kita kena sign dulu dan baru kita print out nanti. Sebab dia tak boleh masuk communication, vital sign post, CMR, semua tu.
Vital sign post. Sebab nanti you kena buat progress note. Nanti you kena buat progress note juga kan. So kalau you print out kat situ, you print out yang macam biasa normal punya prosedur. Saya tak berapa pandai sangat yang normal prosedur tu. So nanti you just documented yang perlu tu. Nanti lepas you buat prosedur, you akan buat juga patutnya progress note. Yes. So sebab macam ni, saya tak kata yang dalam PSA note ni you kena type. Everything yang kena type. At least you type untuk medication. Semua yang kosong-kosong blank tu you boleh tulis. Sebab betul lah, very difficult lah. Kalau kata you type semua everything complete, baru you print, macam mana you nak request untuk drug? Kan? Sebab tu lepas habis prosedur tu, kena buat progress note. Progress note. Tapi kalau SA note saya tak pernah buang. Memang kita simpan.
This is one of the things yang kita selalu up on pasal
Kenapa progress?
jangan I think
Dia kat dia
Faiz was bringing
file PSA tak
isu yang mungkin selalu terjadi lah. Okay, Faiz tanya tadi sebab the thing with PSA form tu kalau tak sign tak boleh print. And so Faiz tanya so macam mana nak isi macam complication semua dan apa yang Kak Ayu jelaskan tadi complication or whatever happens during procedure or whatever complication that you suffer during the PSA tu you have to isi dalam progress note. And this goes back to benda-benda lain lah. Lepas clerking, your initial clerking, record and sign. Progress, buka lah clerking baru. Janganlah nak tak sign daripada awal, lepas tu every time duk top up dekat ED clerking tu. So dia akan nampak clerking tu tak akan represent your train of thoughts and your punya apa benda yang you buat. Sebab bila you clerking, you tak sign and every time review patient just tambah dekat clerking tu, dia akan jadi nampak pelik. And tu yang jadi nampak patient duduk 8 jam kat ED, review sekali je. Padahal in between you keep assessing patient progress and you administer treatment dan sebagainya. And even kadang-kadang EP review pun tambah je dekat scene by kat atas. Dia jadi pelik lah. So every time you tengok patient, you dah habis, record sign. Then next time you review, buka lah progress note. Tak apa. I think dia tak menambahkan kerja banyak pun. Kan? It's just habit kan. Ni mungkin benda habit yang dibawa sepanjang jadi houseman dekat sini. Bila dah habis semua, baru nak sign. Sepatutnya tak macam tu lah. You clerk, you dah sampai plan, record sign lah. So next, result come back ke something happen to the patient, progress note. That will show your train of thoughts. Dan bila masuk audit ke apa, jadi orang tahulah. Oh, mula-mula buat macam ni because whatever. Then something happen, then plan jadi macam ni. Baru make sense. Kalau tak, dia jadi macam pelik. Dia masa ni korang tak berasa lagi. Nanti bila nama korang sendiri yang ada scene by kat atas tu, barulah korang macam, hey, kenapa buat macam ni? Kalau siapa-siapa yang tak aware, PSA note ni bukan untuk dibuang. Selepas siap, PSA note ni hendaklah dikumpulkan dan tempat letak dia kita ada, nanti kalau korang tengoklah dinding kat yellow dengan kat red, ada dinding yang untuk slot in PSA notes yang setelah selesai. Dia ada slot. Dia bukan kata lepas buat tinggal merata-rata atas meja, lepas tu Dr. Fairuz datang, ni bila punya semalam punya buang. Bukan. Dia ada slot dia untuk letak sebab biasa at the end of the year kita akan kumpul untuk as part of our KPI untuk LNPT. Sekarang dah jadi SKU kan. Basically essentially the same thing lah. So bukan untuk dibuang PSA punya notes tu untuk disimpan. Okay. Ada apa-apa lagi soalan? Nak tambah?
Audiens di rumah ada nak bersuara ke, nak tanya ke, kekusutan di minda, ketidakpuasan hati dengan presenter ke?
Dan again lah, reminder PSA ni untuk ED it's ED punya bidang lah. Okay, it's like kalau surgery nak buat operation pun, surgeon tak bagi GA sendiri. So samalah konsep dia. Otto nak buat CMR kat ED, kita lah macam so called NS kan, kata bau-bau bacang dengan NS kan. So macam so sama konsep lah, Okay.
Okay, we are supposed to have intralipid actually in our department because there's a case of in case of lidocaine toxicity. So if possible, I think we should prepare intralipid. So because I think currently we only have it in NS, if I'm not mistaken. We don't have it in ED. And then another thing is prior to your procedure, you're actually supposed to check on your lemon evaluation, because in case there's any risk of patients respiratory collapse and all, then you have to prepare for intubation and all that. Okay, and then post procedure, by right they are not supposed to sign any legal documents lah. At least about 24 hours post sedation lah. Okay, that's all.
I think hopefully everybody pick up apa yang Dr. Suhad cakap. Within 24 hours after PSA, patient tak boleh sign legal documents sebab they are considered under influence and dia tak mentally sound, medical legally lah. So katalah within 24 hours lepas awak bagi PSA kat dia, awak suruh sign borang pindah harta ke apa, tak laku 25th hour boleh lah. 24 hours, within 24 hours tak boleh. Dan I think yang Dr. Suhad cakap pasal airway assessment dan sebagainya ni termasuk dalam Razi punya ni lah, you know, you have to know the complication and you have to have plan in case, kan? Sebab tu that's why airway assessment awal-awal kalau macam patient ada difficult airway semua, get ready lah your whatever buji, video laryngoscope, kan? Supaya macam Dr. Anas pun cakap, kalau something happen, tak adalah semua orang berlari-lari ke sana kemari mencari apa-apa, kan? So it's all about being prepared lah. Okay, you have a plan, you nak buat something, be ready for in case something yang tak ada orang nak berlaku lah, kan? Okay, ada apa-apa lagi? Post CMR tak boleh AOR discharge lah.
Doktor, nak tanya satu soalan.
Sekejap, Barati.
Doktor, kalau peak patient like 5 year less than 5 year old.
Yeah, Barati. Sorry. Can you repeat, Barati? Tak clear.
Body removal.
So 5 years old, yeah.
Ketamine is best or
sorry?
Midazolam is best?
Apa? Ketamine is.
Okay, Doctor, for peak patient less than 5 years old, CT brain ke ataupun remove foreign body ke, midazolam is better choice or ketamine?
5 years old.
Actually, both also can be given as long as you give the correct dose and you monitor adequately. Cuma kalau for very short procedure like CT brain, I think ketamine is better because we back to pre-sedative state faster. Midazolam sometimes is a bit longer and more complication compared to ketamine in terms of pediatrics. Especially if you overdose, over-sedated, and difficult for you also to assess, especially if the child having altered mental status or the GCS is not full lah. Okay, so I think both also can be given as long as you give the correct dose and you monitor post sedation lah. But for the for example oral cavity punya laceration wound dental procedure, best to avoid ketamine lah. Because ketamine as we know, one of the side effect is the secretion kan will be increased. So difficult for the dental officer to TNS, and then sometimes it may compromise your airway if the child really produce so much of secretion. Okay, so I think depends on which situation. If you want a faster, very short procedure, then ketamine is the way to go. If you want a slightly longer procedure, maybe midazolam is okay. But go by lower dose first. Don't terus boom 0.3, 0.5 mg per kg lah. Can start with 0.1, 0.2 mg per kg first, rather than go straight to 0.5. And monitor for the hypotension, respiratory depression, etc. Okay. Does that answer your question, Barati? Oh, lagi lama. Aku tak dengar.
Senyap. Okay lah, so thank you for audience at home and thank you for audience live audience di pentas. I'm done with my presentation. Next ada Kahut. So I pass the floor
Yes,
back
Doctor,
to the.
thank you so much.
Alright. Relax like that.
Can everyone see the screen?
Yes, can see the screen.
Okay. Come on, guys, the one that won last week.
tema Halloween. Tema Halloween kat tu.
Everyone in?
Boleh lah. Semua join bukan nama sebenar.
Can we start?
Ya, boleh lah. Dia nanti kalau dia top scorer dia mengaku lah.
Yep, Flamingo Malaysia. It's a developmentally it happens during the development stage of the child. So it's due to the immature cartilaginous structures. So that's why it causes congenital stridor.
Kelajuan pun ada faktor.
Okay, here we go. So this patient has got a severe croup, so that's why we need to give NAP adrenaline, okay, 0.5 ml per kilo, because we want the vasoconstrictor effect of the adrenaline to reduce the airway edema. But then if let's say you give salbutamol because of the beta agonist, it will cause vasodilation, so it actually worsen the patient's condition. That's why the answer is adrenaline. Go, Isha.
Go. Dapat free.
Right. In bronchiolitis, there's no role of steroids, mainly oxygen and supportive care, and KIV suction. Yep. Bronchiolitis, we need to support, and because it's a severe bronchiolitis, we need to support the patient with oxygen. Okay, adrenaline is not used in bronchiolitis. And physiotherapy, you clear the secretions by suction, not by physiotherapy.
dalam dah rosak dah. Ada dua dalam bilik merah.
Okay, when you see a septic child which is 39 degrees, you need to make sure that the child is not in septic shock. Because if the child has got any signs of shock, then you will need to start your fluid bolus. So you need to determine whether the child is really in shock or is just dehydrated. So that's why we need to, the first priority in this child is to exclude any signs of septic shock. Yep, correct. So we do not give PSA to examine a 6-year-old girl who's in distress after a sexual assault. The rest we need to give PSA. Yep, well done. So we need to continuously monitor the saturation of the patient because this is the first thing that will drop. That's why we need to monitor them continuously and we need to support them with oxygen. Yep. Etomidate suppresses the adrenals. That's why it's not recommended to be used in sepsis. But midazolam doesn't cause emergence reaction. Emergence reaction is usually seen in ketamine. Okay? And ketamine doesn't cause rigid chest syndrome. Fentanyl causes rigid chest syndrome. Okay? All right. So, naloxone reverses the drug of midazolam? No. Tumazanil reverses midazolam. Naloxone reverses opioids, which is morphine. So, midazolam, although rare and very low incidences, does cause paradoxical agitation in some of the patients. Okay? So why do we not recommend rectal and intramuscular use of midazolam? Is because we cannot estimate how long it actually takes for the action to actually kick in. Last question. Yep. So I've reviewed the answer to this. So Flumazanil reverses midazolam. Okay, always remember that. Okay, so let's see the chart for this week. Well done, Hamis. And midazolam.
Tak mengaku.
Okay, so that's all for this week.